Hello everyone, my name is Owen Brennan, Medical Affairs Dietitian at VitaFlow International. I'm very pleased to welcome you to today's webinar, which will cover the GMDI VLCAD Guidelines 2019 update. This is part 2 of a 3-part webinar series titled High MCT Diets in Long-Chain Fatty Acid Oxidation Disorders, Evidence, Guidelines and Implementation. I'll provide more details on the other 2 webinars at the end of this webinar. A few housekeeping items before we get started. The webinar will last approximately 60 minutes and will include time for questions at the end. If you would like to ask a question, please use the question feature on your GoToWebinar toolbar. All questions will be screened and a select number will be answered by the speaker at the end of the presentation. The webinar is being recorded and will be available on VIA in the next 2 to 3 weeks. You can access PDFs of the presentation slides, a certificate of attendance, and a self-reflection tool in the handout section of the toolbar. Please take time to download these now, as they will not be available once the webinar has finished. To allow for greater interactivity during the webinar, we shall be running a few polls. When used, you will be given the opportunity to answer questions raised by the speaker. During the last webinar, we were asked to provide a bit more information on how to go about asking a question. So that is covered in this slide. If you look at the top right-hand corner of your screen at the moment, you will probably see a menu bar that looks a little bit like that, quite a slim menu bar. If you press on the orange arrow, what happens is that the menu bar will pop out fully. So what you need to do is go to the questions, and on the questions bar, if you click on that arrow, that will open up the question panel so you can type a question. If you're finding that it's a bit tight to do your typing, you can press on this symbol here, and that will pop the question panel out into a larger separate window, and some people find it easier to type that way. There now appears a disclaimer on screen. In summary, the views herein are of the presenter and do not necessarily represent VitaFlow's views. The material herein is accurate as of the date presented and for educational purposes only. It is not intended as a substitute for medical advice. So with all that said, VitaFlow is delighted to introduce our speaker for today's presentation, Dr. Sandra, or as many people know her, Sandy Van Kalkar in Oregon, who, like our first presenter in the series, is sitting approximately 7,600 kilometers away from where I am in Liverpool. Dr. Van Kalkar is a founding member and past president of Genetic Metabolic Dietitians International, or the GMDI. She is a registered dietitian. She is an associate professor in the Department of Molecular and Medical Genetics and affiliated with graduate programs in human nutrition at Oregon Health and Science University. She was chair for the VLCAD Nutrition Guidelines Work Group. VitaFlow would like to thank Dr. Van Kalkar for taking the time to present for us today. And without further delay, I'd like to hand over to her. Please bear with us here as it can take a moment for the controls to be passed over.
Okay, hi everybody. I wish I could see everyone, but first of all, I want to thank VitaFlow for inviting me to give this webinar about the VLCAD Nutrition Management Guidelines. The Nutrition Management Guidelines, we have been working on various guidelines for about 10 years now. And really the purpose is to foster optimal nutrition management of individuals with inborn errors and reduce the uncertainty and variability in the management of patients with inborn errors. So our first nutrition management was MSUD, which came out in 2014, PKU 2016, propionic acidemia in 2019, and then VLCAD, which on the website was out in 2019, and we just finished a publication in Molecular Genetics and Metabolism. So why do we need a guideline? First of all, management has evolved, especially with newborn screening. There's very limited literature most of the literature, or a lot of the literature, does not describe diet management other than to say the patient was put on a low-fat diet with MCT. Few details are included in most cases, and there is a lot of variability in practice, not only here in the US, but in different areas of the world. People are treating VLCAD in different ways. So the nutrition guideline process was quite involved, and we wanted this to be transparent and to take into account the different sources of evidence that we do have. So we first completed a review of published literature. We also included gray literature, which is things like book chapters and abstracts. We then completed Delphi 1, which was a survey of MDs and RDs in different parts of the country. And then both of those sources would put into summarized and preliminary recommendations were developed. These were taken to a nominal group. We had about 15 people, MDs, RDs, researchers, and also a parent representative. This was a face-to-face meeting, and we discussed the areas of variation, developed recommendations, and voted. We then completed another Delphi. Here we took areas of continued difference within the nominal group and put that through a Delphi process to send out to a different group of MDs and RDs. And then finally, all of this information was put into the final guidelines. There was also an external review process and field testing, and in the end, we had 94 people who contributed in this process. So where do we find the guidelines? The website is listed at the top, southeastgenetics.org. Here you find the management guideline portal. In the guideline section, you will see the different guidelines that have been developed. You can go down to VLCAD, and that'll take you directly to the web-based guideline. These are the different sections that are in the web-based guideline. I'll point out a couple. So the nutrition recommendations section includes 6 different questions that we worked on, and we'll review highlights from each of those in this webinar. There's also a list of different tables, which I think people find very helpful, and again, I'll point out some of those in the talk. One thing that we needed to keep in mind when developing these guidelines is that there is a continuum of different phenotypes for VLCAD. There's the severe phenotype, also called the cardiac phenotype. These individuals can become sick quickly and can develop cardiomyopathy and other cardiac problems. The moderate phenotype rarely develops cardiac problems, but they are prone to episodes of low glucose and low ketones, especially during illness or other stress. And then there's the mild phenotypes, or also called late onset. This group tends to not have problems when they're younger, but can develop muscle problems and rhabdomyolysis episodes in adolescence or early adulthood. So the first poll that we have, and this is mostly for my information because I'm kind of curious what people are doing. So the question is VLCAD included in your country's newborn screening panel? So if you can quickly answer that. Oh, okay. I can, in the US, we do have newborn screening in all the states. It looks like the people that are on the webinar, about half have newborn screening and half don't. And then there's some that are not sure. So that's quite different than what the answer that we'd get if we were speaking mostly to individuals from the US. So newborn screening has definitely changed the number of individuals that we pick up with VLCAD. Prior to newborn screening, the incidence was estimated at about 100 in, or 1 in 100,000. It's now estimated as low as 1 in 30,000. And the big reason for this is that with newborn screening, we are picking up milder cases of VLCAD. So when we get a positive newborn screen for VLCAD, the way that we're doing this is deciding, looking at the infant, if the baby is asymptomatic, we tend to treat as a mild VLCAD. We allow breastfeeding or standard infant formula. If the infant is symptomatic, we treat as a severe or moderate VLCAD. We restrict long chain fat and add MCT. And these groups are interchangeable. So based on genotype, confirmatory testing, or clinical symptoms, those that are in this group can change and be put into the severe or moderate VLCAD. But until we have evidence of the genotype and associated phenotype, we tend to treat our babies as mild VLCAD as long as they remain healthy, and we do allow breastfeeding. So there are 6 questions that we addressed in the guidelines. The first question is about nutrient intake. This addressed the healthy individual, and we looked at fasting, diet composition, breastfeeding, essential fatty acids, and cornstarch. These are the fasting guidelines that we developed. And again, it depends on the phenotype, how long we are allowing individuals to fast. But we have different age groups. For the severe phenotype, these are the hours that we are allowing as maximum fasting time. And then for moderate or mild phenotypes, the range is longer. We often allow a longer fasting time in those with milder forms of the disorder. This is one of the tables in the guideline with laying out diet composition. Again, we're giving different age groups. Total fat is not restricted, so that would include both long chain and medium chain fat. These recommendations as percent of total energy are consistent with the DRIs here in the US. Energy intake for the great majority of individuals with VLCAD is consistent with general recommendations for the population. Sometimes the severe individuals may need less or more energy, but in general, most people do tend to use a typical amount of energy, as well as protein. So these protein intakes are consistent with the DRI. Where things vary is with the long chain fat and medium chain fat, and the amounts change depending on the disease severity. So for instance, here a 0 to 6 month old with a mild form of the disorder, we might not even add MCT. So we might leave that out or add in a small amount. With more severe phenotypes, such as moderate or severe, the amount of long chain fat is restricted. Those with the severe phenotype is 10 to 15% of total energy. Breastfeeding, below is a chart where we asked RDs and MDs whether they felt an individual could exclusively breastfeed as a neonate. There was agreement that the mild individuals could, less agreement with moderate, and very little agreement for the severe phenotype. So the recommendations are to allow breastfeeding without MCT for the mild phenotype. For moderate, we can allow breastfeeding, but consider supplementing with a low long-chain fat, high MCT medical food. And then for the severe phenotype, the primary source should be a low long-chain fat, high MCT medical food. This is a table in the guidelines with the different medical foods that are available. I know in Europe, Lipostart and Monogen are available. This table will provide the total amount of fat as a percent of energy. You can see it varies greatly between the different types of formulas, ranging from 24% of total calories from fat to 48%. Long chain fat also varies, ranging from 4 to 23% of total calories. And then MCT also varies, ranging from 20 to 37% of total calories. We also list the sources of MCT. They're liquids, emulsified liquids, the oil, powders. This table lists how much fat and how much MCT is provided from each of these different sources. One of the questions that comes up is for the older individual, how do we give them the MCT? This is a question, again, that is very individual, but there are either choices to add MCT to a milk or other beverage, or MCT can be added to food. Most patients, I will say, do a combination of these two, but there is a new cookbook called the Fatty Acid Oxidation Disorders Kitchen that gives recipes using MCT oil. The order information is at the bottom, so a newer resource for patients. For cornstarch, cornstarch has traditionally been used at bedtime for individuals with VLCAD. In the literature, cornstarch is used a lot, but the nominal group especially felt that supplementation with uncooked cornstarch at bedtime is not indicated, since hypoglycemia is not likely to develop when an individual is asymptomatic, avoids excessive fasting, and is meeting their energy needs. This was agreed in Delphi 2. RDs agreed with this statement, whereas MDs did not. So overall agreement was 69%. But we are recommending using a bedtime snack, emphasizing complex carbohydrate rather than cornstarch. For those who are unable to sleep through the night and do require a source of energy at night, we are suggesting using overnight enteral feeding rather than cornstarch. For illness, we looked at diet composition, strategies to prevent decompensation, and then illness management both at home and for admissions. What we found when we reviewed the literature is that the diet, the recommendations vary depending on whether the individual has cardiomyopathy or is experiencing an episode of rhabdomyolysis. So in this chart, these are the different references that we cited. But if you look here, those individuals that had cardiomyopathy, 100% of those patients were prescribed MCT. That's in comparison with the individuals who were experiencing rhabdomyolysis without cardiomyopathy. And here you can see that only 44% of those patients were prescribed MCT. So based on this difference in the literature and also based on the Delphi surveys, we are recommending that in acute rhabdomyolysis that we emphasize carbohydrate as the primary energy source, and MCT is probably more helpful in those that have cardiomyopathy issues compared to those that are experiencing only rhabdomyolysis. At home management, for mild illness at home, we want to provide frequent high carbohydrate feedings. These can include glucose polymers, simple or complex carbohydrate sources. We did ask in the Delphi survey whether glucose polymers were preferred over other carbohydrate sources, so preferred over juice or other foods like that. For infants, the MDs definitely felt that it didn't matter if you used glucose polymers, that juice or other carbohydrates were fine. The RDs definitely did not agree with that. But for older individuals, children to adults, both groups agreed that you don't have to use glucose polymers and that other sources of carbohydrate are sufficient. We want to strive to achieve usual energy intakes rather than trying to push additional calories. And again, there wasn't consensus that glucose polymers were the preferred source of carbohydrate. For admissions, in consultation with the medical team, to use a minimum of 10% IV dextrose with electrolytes at a rate of at least 1.5 times maintenance fluids, or 8 milligrams per kilogram per minute. Consider central line placement for those that have frequent hospitalizations, and to avoid the administration of IV lipids. However, if an individual is on parenteral nutrition for an extended period of time, after 7 days, a source of essential fatty acids should be provided. So in the literature, children develop biochemical evidence of essential fatty acid deficiency after 7 days. In adults, it's after 10 days. And so if someone is on parenteral nutrition for an extended period of time, we do need to add a source of essential fatty acids to prevent deficiency. Another thing that we're emphasizing is even if you have an individual with mild VLCAD, they're still at risk for metabolic decompensation. So this is just a paper of an infant who died at 38 hours in a metabolic crisis without cardiac involvement. His genotype was associated with mild disease. So even if an individual is classified as a mild phenotype, they still are at risk for decompensation and should be given an emergency protocol. Another question was about supplementation. So we looked at carnitine, triheptanoin, bezafibrates, and various vitamins that have been used in conjunction with diet. We did give a recommendation for carnitine. We did not give a recommendation for triheptanoin. Triheptanoin, or C7, has just been approved in the US by the FDA. So this is going to be reserved for an additional supplement to the guidelines. But carnitine still is controversial, whether carnitine supplementation is required for those with VLCAD. We know that it increases the production of long-chain acylcarnitines that may promote toxic effects, especially for cardiac tissue. Because of this controversy, The recommendations are to not routinely provide L-carnitine, but to monitor levels routinely, supplement only if free carnitine concentration is less than 10 micromoles per liter, and to start with a low dose, 10 to 25 milligrams per kilogram per day, and only in supplement to the point that levels remain within the normal range. For monitoring, we looked at various labs. We looked at labs for routine monitoring, conditional monitoring, and also provided recommendations based on age. So routine monitoring are labs that all individuals with VLCAD should be monitored with. Two labs are in this category, including creatine kinase, or CK, and plasma carnitine profiles. So all individuals, regardless of phenotype, these two labs were considered the most beneficial. For conditional monitoring, so conditional monitoring means that we're considering the severity of the disorder and age, etc. So labs that are in the conditional category include the acylcarnitine profile, metabolic panel, especially glucose and liver function tests, for those that are on a fat-restricted diet to measure essential fatty acid profiles and fat-soluble vitamins. And then those with a severe phenotype who have either had cardiac issues or are at risk for cardiac issues, to include cardiology assessments and two labs, troponin and B-natriuretic peptide, or BNP, for monitoring. I do have a poll question about this. So the question is, do you use acylcarnitine profiles to determine if changes are needed in a patient's diet? Yes, no, sometimes, I don't know. Okay, a wide range of answers here. Most people do not routinely use acylcarnitine profiles. Some do. It seems to be a split in the participants and whether they use it or not. Here in the US, we typically used acylcarnitine profiles with routine monitoring. The traditional way that we did this was to add up the different long-chain acylcarnitines. If the total was less than 2 micromoles per liter, that suggested good metabolic control. If it was over 2 micromoles per liter, that suggested that we needed to look at the diet. We no longer feel that this is useful. Clearly, in research studies where we have control of the amount of fasting, we have control of diet composition, etc., there is a correlation between the diet composition and acylcarnitine production. But in a clinical setting, we're now considering that acylcarnitines are not the primary indicator of nutrition management. They vary greatly. They are not predictive of symptoms. Some individuals can have high acylcarnitines and remain clinically normal, and vice versa. They are also affected by fasting time, physical activity, or illness. So we are trying to reduce the importance of acylcarnitines when it comes to deciding if diet needs to be changed or not. For essential fatty acid monitoring, we've got the two pathways, omega-6 and omega-3. The omega-6 pathway is going to have linoleic acid and its product arachidonic acid. The omega-3 pathway is going to have the precursor alpha-linolenic acid and the product DHA or docosahexaenoic acid. So when interpreting essential fatty acids, we feel the most important things to look at are the absolute value of arachidonic acid, DHA, alpha-linolenic acid, and linolenic acid. Using either plasma or red blood cell values are acceptable. One thing that we do want to point out is the Holman ratio, or it can be called the triene to tetraene ratio. This does not give you information about a patient's omega-3 fatty acid status. So if you're concerned about their omega-3 intake, that is not a ratio that's going to help you with the interpretation. For supplementation, if blood levels are low, linoleic acid at a total of 3 to 6% of total energy is recommended. Alpha-linolenic acid, 0.5 to 1.2% of total energy. If only DHA is low, you can supplement just with DHA. The recommendation is 60 milligrams per day for infants and toddlers and 100 milligrams per day for older individuals. These are the different oil sources of essential fatty acids. You can see if you want a concentrated source of linoleic acid, safflower oil is the highest. If you're looking for a source of alpha-linolenic acid, flaxseed oil is the most concentrated. If you're trying to get a good blend of both linoleic and alpha-linolenic acid, walnut oil does have an optimal ratio of the two and can be added. Other oils will provide some linoleic or alpha-linolenic acid, but will also include a lot of other fatty acids which can contribute to the intake of long-chain fat in the diet. Question 5 was about exercise. Here we gave recommendations for activity, pre-exercise diet, and then nutrition needs during and after activity. A change in with the guidelines is to try and get away from discouraging activity for individuals with VLCAD and rather encourage activity. Routine physical activity can promote lean body mass, lower heart rate, may improve muscle substrate oxidation. And so, especially for younger individuals, we actually want to encourage them to be physically active as tolerated. We want to assure that they're getting adequate energy and protein to maintain lean body mass. In general, for all individuals with VLCAD, 20 minutes of physical activity appears to be safe. For some, activity greater than 45 minutes may cause problems. In general, we're recommending that those with mild and moderate phenotypes, when they're healthy, do not need to limit activity. Those with severe forms, it may be necessary. The other thing we want to point out is the awareness of kids playing. I think sometimes we think of activity as sports, whereas kids around 3 to 5 years of age, that's often when they do develop rhabdomyolysis, if they have a severe form of the disorder. And so we want to support them to allow play without developing muscle problems. Providing carbohydrate before activity is recommended. If that is not sufficient to prevent muscle aches or other problems, then pre-exercise MCT is recommended. Here we want to give MCT 20 minutes or up to 45 minutes prior to exercise. These are the doses that are recommended. So for total body weight, 0.1 to 0.3 grams per kilogram. It's recommended to mix this in a glucose solution, so juice, Gatorade, or similar. Smaller doses may be needed for those with GI intolerance. And the other thing we want to emphasize is the potential to gain extra weight with excessive MCT. So rather than adding MCT to the diet, we're suggesting moving some of their usual MCT doses prior to activity rather than adding additional MCT. This is a handout that is available in the toolkit, which Mary Sawa will be discussing in the next talk in this series. But here we are giving recommendations for pre-exercise and then also post-exercise nutrition recommendations. And this can be individualized based on the patient. Question 6 was about pregnancy. So here we are discussing the premenarchal period, pregnancy, delivery, and the postpartum period, providing nutrition recommendations and monitoring guidelines. There's very little out there about young women prior to menarche. There is one case report where this female had more problems with rhabdomyolysis in the year before puberty compared to the year after puberty. So that year before puberty, she had 10 hospitalizations compared to only 3 hospitalizations after menarche. So we want people to be aware that that time before puberty can have a lot of problems for those that are at risk for rhabdomyolysis. So maternal VLCAD, there's very little in the literature. There's 4 published papers and 12 cases. All of these women had a history of muscle problems and rhabdomyolysis. One had a history of non-ketotic hypoglycemia episodes as a child. So 2 of these 12 pregnancies had complications during pregnancy. One woman had hyperemesis gravidarum, muscle aches in the first trimester, but then actually saw improvements in labs and symptoms in the second and third trimester. In contrast, another woman had increasingly severe rhabdomyolysis as pregnancy progressed. In the postpartum period, the women did have return of their muscle symptoms at 4 to 8 weeks after delivery. In one of the women, heart failure developed at 10 days after delivery. Infants appear to be normal at birth. However, there really has not been any follow-up of these infants as during childhood to really know if there are concerns for the infant or not. So recommendations, there was not a consensus whether low-fat diets are needed. There was consensus to include MCT with those with a moderate or severe phenotype. It may not be necessary for those with a mild phenotype. And so we're emphasizing continuing the same diet recommendations during pregnancy as before pregnancy, but to expect increasing energy needs as pregnancy progresses. Fasting tolerance may decrease the farther along into pregnancy the woman is. We want to minimize catabolism during labor and delivery and monitor the woman for a minimum of 8 weeks after delivery, given the higher risk for complications. There isn't a contraindication to breastfeeding, but realize that there will be an increase in energy needs, and so the woman will need to be aware of that. So with these different guidelines, there were some changes in directions compared to recommendations prior to this. We want people to realize that the severity of VLCAD is a continuum. It's not distinct categories of mild, moderate, and severe. So an individual, depending on their clinical status, may need to follow recommendations in these different categories. For mild VLCAD, the trend is towards not modifying diet, but continuing to monitor even if the patient remains asymptomatic. We want to promote breastfeeding, especially in mild VLCAD. For symptomatic VLCAD, total fat is not restricted. We want to restrict long chain fat, 10 to 30% of total calories, and then the remainder provided as MCT. We want to reconsider some of our practices, such as providing cornstarch at bedtime and routinely using carnitine for all individuals with VLCAD. And we also want to encourage exercise as tolerated and support exercise with sufficient energy and fluid intake. A question is, are these guidelines and recommendations for VLCAD applicable to other long-chain fatty acid oxidation disorders? So yes, they are. Both VLCAD and CPT2 tends to have this wider range of phenotypes. So using some of the recommendations in this guideline based on the severity of CPT2 is appropriate to use. For those with LCHAD and trifunctional protein, we are recommending that they follow the recommendations for a severe form of VLCAD. These two disorders tend to have a more severe progression, and so we recommend using the recommendations in this category. Some additional resources, again, a publication is coming out in molecular and medical genetics. There's also a toolkit, which Mary Sawa will talk about in the next installment. We also developed a couple things for consumers, a frequently asked questions handout, which I have here, also a consumer summary that can be used for patients. And then we also plan to update the guideline to include recommendations for use of triheptanoin, hopefully soon. And finally, I want to thank the VLCAD work group. Ronnie Singh from Emory University is the PI, and Fran Rohr from Boston is the co-PI. Mary Sawa was the co-chair. And then I have photos of all the different individuals who worked on the guidelines with us. And then also to acknowledge that a HRSA grant was used to support this activity. And with that, again, I want to thank VitaFlow and can open it up to different questions.
Great. Thank you, Dr. Van Kalkar, for taking us through this topic in so much detail. It must be so challenging to produce guidelines for a disorder in which individual genotype-phenotype relationships are really difficult to pin down. So we have a few questions that are being submitted, and I'll ask you the first of those now. We have a question, the first question is actually a three-parter, and it relates to newborn screening. Is C16 the screening analyte, and does the blood spot concentration help decide your treatment category? And the third part of that question is, what day of life do you screen at? Okay, so screening here in the States, typically we do at 24 hours of age, sometimes up to 48 hours of age. The primary analyte that you see in VLCAD is C14-1.
so 14 carbons and 1 double bond, but you will see elevations in C16 and some of the other long chain acyl carnitines as well. And then I'm sorry, the third part of the question.
The third part of the question, does the blood spot concentration of C16 or presumably the other analytes help decide your treatment category?
Okay, that is a really good question. In general, we do use the elevations in the acyl carnitines as an initial predictor of the phenotype. So those with the lower amount of acyl carnitines tend to be milder, and those with high elevations tend to be more on the severe end of things. And initially that works, but certainly after you've done the confirmatory tests, such as additional acyl carnitines and genotype, you tend to be able to be more exact in which category they fit into. In general, that works well, although sometimes we see individuals with really high C14-1 who ends up having a milder phenotype than we predicted, and vice versa. So it's helpful, but certainly not definitive. But I will say that with newborn screening, you will pick up a lot of milder forms of VLCAD, which can be good, but it also can be confusing because we really are not very good at determining when those individuals may develop problems later in life. So it's kind of a two-edged sword.
Okay, no, thank you. Another question is that the baby with the mild mutation who then developed severe symptoms was 38 hours old. Do you think this risk remains in older children with a mild mutation?
Certainly the older the individual, the less risk there is for metabolic decompensation. But you really can't say that for sure. So even those with a milder phenotype, we provide an emergency protocol. We give them recommendations for treating illness. We do the same kind of things as we would with a moderate or severe phenotype. If the illness is severe enough, yes, there is a possibility that problems could develop. Again, much less risk, but we also feel that it's important to let families know that it's not a 0% risk if somebody has a mild phenotype, that they are guaranteed not to run into problems if they do become really ill.
Okay, thank you. The questions are starting to come in a bit faster now. How long do you monitor heart echocardiogram before deciding that the patient is not a cardiac phenotype?
That's a good question. I mean, we certainly do a cardiac workup for all babies, regardless of what we think might be their phenotype. And then we really rely on the cardiologist beyond that. So based on testing, the cardiologist may recommend a longer term, yearly visits or whatever, but we do rely more on our cardiologist to make that determination rather than us deciding that they no longer need any cardiac follow-up.
Okay, thank you. Please, can you explain the practical details of the emergency regimen or sick day plan if you do not use glucose polymer? Oh,
okay. So I'm happy to send these to for distribution, but they're also in the toolkit. We do have recipes using juice and it's primarily juice or sports drinks. You can add additional sugar or something along those lines to increase the calories. But I will say for older individuals, just frequent consumption of juice or popsicles or something along those lines seems to work just as well as a polyco solution does. I think we still use polyco solutions for infants and young kids. Again, MDs may not agree with that, but certainly the RDs do. I think in the end that's easier. We do have recipes using Pedialyte with additional polycos. So again, those are part of the toolkit, and I know Mary will talk about them next time.
Okay, great. For young children, how long should they rest between bouts of play?
That's another really good question, which I don't really think we have a good answer. I think it's more individual than it is a general recommendation, but we usually suggest that kids, take a rest, drink something with some carbohydrate at least every 20 to 30 minutes. So it might be, might be too much. They might not really need to do it that often, but we also kind of want them to get into kind of a habit of knowing that they need to stop and that they need to have some calories when they are really busy or participating in sports. So usually 20 to 30 minutes has worked pretty well. Again, some people really, especially when they're older, may not be able to go that long, but I think for younger kids that tends to work pretty well.
Okay, thank you. And then the final question, could you please explain why the guideline suggests moving away from cornstarch overnight, and why overnight enteral feeding was favored?
So the feeling is that if an individual takes enough calories, carbohydrate calories, prior to bedtime with an older individual and they're healthy, they're not sick, but they can go that full amount of time and not develop hypoglycemia. In the older an individual becomes when they're healthy, the less of the chance that they are going to develop low glucose levels in the morning. So in general, most people do just fine without cornstarch. We do have a couple kids with severe forms who really cannot go that full night, and it just G-tubes tend to work really well. In those kids, cornstarch might not last as long as, may not be sufficient to prevent problems in severe phenotype. And so for those, we tend to go more towards using G-tubes rather than cornstarch. That being said, there's nothing, there's nothing harmful about cornstarch, but we're trying to make the point that very few people or very few individuals with VLCAD actually require it.
Great. Okay, no, thank you. So once again, I'd like to thank Dr. Van Kalkar for taking us through the GMDI VLCAD guidelines update today. For everybody listening, we hope the presentation has been informative and helped advance your knowledge in this area. Before we conclude, I would like to take another opportunity to remind you of the other two webinars in this series. Dr. Melanie Gillingham's webinar is now available to view on VIA. Mary Sowa's presentation will take place on November 3rd at 7 p.m. GMT, not BST or British summertime, as daylight savings will no longer apply. Full details and registration links can be found on VIA. So with that concludes today's webinar. And on behalf of VitaFlow, we would like to thank you for tuning in today. Please take the time to complete the evaluation questions before you leave the session. Goodbye and enjoy the rest of your day.
Thank you.